Bonjour à tous.
Good morning. First of all, I would like to thank the Academy for having invited me to talk to you briefly about sudden cardiac death and what we're doing to handle this in the Paris region. Sudden death is not a disease, it's a way of dying. Because it's a way of dying, this complicates the situation somewhat. Sudden death is like an unexpected cardiac arrest in the absence of symptoms, or within an hour after the onset of the first symptoms, in the absence of any obvious extracardiac causes. The epidemiology of sudden death is like the epidemiology of coronary artery disease, because the vast majority of sudden deaths are due to the coronary arteries. Over the last 30 years, when we wanted to identify predictive factors for sudden death, comparing a sudden death group with a non-sudden death group, then we ended up with the risk factors for coronary artery disease. The current challenge is to know amongst CAD patients which ones may suffer from cardiac arrest. Strangely enough, contrary to atrial fibrillation, ventricular fibrillation is always instinctively viewed as a fatal condition. Probably because we know we can't do anything when there is a cardiac arrest. When you intervene early on, cardiac arrest should not be viewed as fatal. And finally, there's one last slide to introduce the topic. If you look generally at the various strategies which we have to reduce the number of sudden deaths in France or in India or where have you, we have different tools. Either we wait for the event to occur and then try to ensure the survival rate is much greater than the current figures in France, or else you do everything to avoid the event actually occurring. For the event not to occur, either you say it's a problem of CAD, I'm going to try to prevent the development of CAD, or you do a risk stratification. You identify amongst the most high-risk patients those who would benefit from protection. And this risk stratification is worthwhile because we can propose something to the most high-risk patients, that is, either pharmacological treatment or a defibrillator, an implantable defibrillator, for example. Sudden death gives rise to many problems. Indeed, we need to have very precise epidemiological data. I'd like to insist on that. For epidemiological data, you need to do research on the general population. You need better to understand the mechanisms for the onset of atrial fibrillation. You need fundamental science. You need clinical science. Data on hospitalized patients, but sudden death is far broader. You have the issue of prevention. In similar cases, you have the issue of population education. It's a public health problem. You need to educate the general population on how to save lives. Also assistance. You need to be able to save patients in cardiac arrest, but why not provide for assistance for patients who will never recover, maybe, but we could perhaps recover their kidney. And then there's another important dimension, in addition to the ethical side, it's the psychological issue. Sudden death is a major trauma, be it for the survivors, but above all, the close relatives. So you have any number of issues that are involved. We realize it's not just a cardiological problem. In this context, therefore, we set up our sudden death unit at Pompidou Hospital. We have combined any number of skills in order to work on sudden death with various partners, academic partners, public and private partners. In our sudden death expertise center, which of course had to be located somewhere, and so it's located at Pompidou Hospital. This is the upshot of broad cooperation throughout the Paris area. We have developed a research program for the general population in order better to understand the epidemiology of sudden death. We have different tools, registries, cohort follow-ups. We follow up 10,000 patients for 20 years. And we have a case control approach. Because we're in Paris, I'd like to insist on a couple of epidemiological figures that pertain to Paris. We set up a registry in Paris in May 2011, which covers the 4 Île-de-France departments. We set up a good system. In the minutes following cardiac arrest in these 4 departments, we are informed of the situation and we can follow what's happening in real time. If we can see whether the emergency services manage to resuscitate the patient or not, or whether he dies on the spot. If the patient is taken to hospital, we make contact with the hospital team in order to follow the patient until he is discharged. And the patient is then followed when he leaves the hospital alive. That's a minority of patients, but when they're fortunate and they are discharged from the hospital, then they are seen again twice a year. The problem with sudden death is that it's hard to get precise information because usually the patient dies before you can study the case. And this is why we have established cooperation with the social security system. We can recover all the records we can access all the patient records prior to his death. Since the 15th May 2011, we have had over 18,000 out-of-hospital cardiac arrests, over about 3,000 had an extra cardiac etiology, 9,000 sudden deaths with attempted resuscitation. We collected information on all these cases. If you extrapolate, based on the 6.6 million inhabitants, 10% of the population, one can estimate that the number of extra-hospital deaths from sudden death is 38,000 in France. So how can one sum up the population? The average age is 65. Half of the population is under 65, the other half over 65, 2/3 men, 1/3 women. Sudden death mainly occurs at home. Cardiac arrest in the streets amounts to only about 1/3 of the cases. Cardiac massage is given only in half the cases by the immediate witness of the event. In 1/4 of cases, the emergency services have find still a valid pulse. What we've discovered is that women aged 40 or 50 have 30 times fewer chances of suffering from cardiac arrest during sport than a man of the same age. In terms of etiology, it's a coronary artery disease that represents the vast majority, be it chronic cases, prior infarction, or coronary syndromes. And electrical anomalies in a healthy heart represent only 5 to 10% of the cases. Now let me say a few words about the fate of these patients. You can see the view of the cardiologist talking about a sudden death. It's a bit biased because less than 1/3 of patients turn up alive in the ICU, and cardiologists only see 7% of the survivals of sudden deaths that occur each year in France. And if you look at this on a national scale, we have the sports-related registry. This covers 60 French departments. Survival varies hugely according to districts. Some districts have a 0% survival rate when there is a sports-related SCD. In other departments, in the Côte d'Or and in the north, like Lille, there the survival rate is 43%. And you can see that these differences are mainly due to what the witness does at the time of the cardiac arrest, whether there is cardiac massage given or not. The registry enables us better to understand, for example, where we need to have defibrillators in Paris. This has enabled us to assess over 2,200 areas, and we wanted to see where most sudden deaths occurred outside hospitals. We realized was that, and it's not logical, that these cardiac arrests are very heterogeneous in Paris, but they mainly occur in train stations and near train stations. So mainly in train stations, because the flow of people in train stations is huge compared with other pavements. But if you have the same flow of people, train stations are still the main location compared with places where there are equal numbers of people and places which are not train stations. And we also realized the second thing. Sudden death is not all that sudden. Sudden death isn't all that sudden because when you really look into the patient's past medical history, in 50% of the cases, a patient has the typical symptoms like chest pain, syncope, angina. These patients have usually consulted emergency services or a medical practitioner or a GP. A patient with symptoms will call up the number 15, and he has seven times more likelihood of surviving his cardiac arrest than if he calls the emergency service. So in other words, we used to base ourselves on defibrillators, traditional prevention, but now we think about subacute prevention. We have new technologies, and we should be able to identify CAD patients who are at risk of cardiac arrest in the next few minutes or hours. And we're currently working on why these patients are at high risk or low risk of atrial fibrillation. So I've talked to you about the epidemiology of our sudden death expertise center, but you have now seen that the problem is far broader than that, and many of us are working on the issue, and thank you for your attention.
Thank you, Professor Marijon. As you said that the time is the most important factor here, but time is not in our hands in these cases. So maybe that we must screen the patients and who are the potential patients who may likely to go for the sudden cardiac death. And secondly,
the older one.
And secondly, we must educate the public at large for the basic cardiorespiratory resuscitation. That's why under the guidance of our director, various courses are being started at the Institute for the public at large, for the basic paramedical staff, for the medical staff at the various levels. So that if we can provide this resuscitation on the spot, whoever has seen that patient is, somebody has fallen down or going for the cardiac death or something, he can be resuscitated. But main thing will be to screen these people, screen the public at large to see whether any of these patients are at high risk for the sudden death or not. Any questions, please?
Thank you. I'd just like to congratulate Professor Marijon for his excellent presentation and the wonderful work he's done on sudden death. I recall that the Academy of Medicine in 2007 managed to introduce a fabulous decree. Anyone, even if they're not a doctor, can use a defibrillator on a wall or in some public area. In the past, non-medical personnel wasn't allowed to use a defibrillator. This changed in 2007. And the Academy of Medicine at the time also managed to get the number of defibrillators available increased. In the past, there were very few available, not even in sports fields. So I think the Academy of Medicine has played an important role in the prevention of sudden death. But you're quite right, a lot remains to be done in order to screen for people at risk of sudden death. I think that the panel will not be able to take place because we have to start the next session, a session on infectious diseases. I'd like to thank our speakers. I'd like to thank our speakers and Professor Aran for this wonderful session on cardiology.